about pulmonary sarcoidosis today. And the reason for this is because most of the patients that have sarcoidosis, they be seen by a pulmonary doctor, because more than 90% of patients with sarco, they have some kind of, they are affected in the lungs in some way. So as Dr. Barney explained, sarcoidosis is a disease where there is the presence of non-caseating granulomas. There's a tons of inflammatory response there. A lot of these chemokines, some of them TNF alpha and TGF beta are the ones that are kind of circulating. So, and these chemokines are there making you feel really, really sick, really bad. So talking about the clinical presentation, particularly talking about the lungs, you can have these generalized symptoms of just feeling fatigue, having these night sweats, some fevers, rashes if you have extra pulmonary symptoms. But from the pulmonary point of view, it's this vague chest discomfort, this chest pain that you have had, like a stress test, a cardiac cath. They told me my heart was fine, but I have this relentless chest pain. Some cough. The cough can be dry or can be productive, so you can be making up some phlegm, as well as short of breath, and also sometimes wheezes. You make the diagnosis, as I said, Dr. Barney did a very good explanation of it's like a little bit of a road to go through. Because many of my patients, they told me I had cancer, and they did a biopsy, and they now have sarcoidosis. But you want, sarcoidosis is a diagnosis of exclusion. So you want to make sure, yes, but number one, the patient doesn't have cancer, there's not an active infection, and is it make sense clinically, radiologically, and then pathologically. And in many instances, as a biopsy is necessary. We do these biopsies as pulmonologists. Sometimes the surgeons that do them. We can do it with a bronchoscopy, which they go with a little camera down your mouth, into your throat, into your lungs. They can take little pieces of tissue with this bronchoscope, these little forceps. They less than 1 millimeter pieces that we can see the granulomas in there. We actually go in and take pieces of the lung tissue itself. We also have other modalities where we do it's a technique called EVUS, which is an endobronchial ultrasound, where we go in with the same instrument, but instead of having the forceps, we have an ultrasound probe, so we're able to look at the lymph nodes inside your lungs, and then we go in with a needle inside those lymph nodes, and we take little pieces. So these are really minimally invasive techniques, so they can give us a lot of information about what's going on with your lungs. And the other diagnostic techniques or biopsy techniques could also be having a surgery, like Dr. Barney was saying, a mediastinoscopy, or an open lung biopsy when they go on your side and they take bigger chunks of your lungs. Also, breathing tests. So the breathing test helps us as pulmonologists to kind of gauge how's your lung function doing, if there's any decline in your lung function, if you are restricted or obstructive. And the way I explain these to patients is, so we see obstruction when patients that have COPD, that wheeze, that have asthma, or restriction in other patients that have like pulmonary fibrosis or scar tissue on their lungs. And in sarcoidosis, you can see both. Initially, it was first thought that only restriction, scar tissue, we will see like that on the breathing test, but you can have both patterns. And this is very helpful as a clinician to know which patient needs to be treated more aggressively or who is okay just to watch and see. So now let's talk a little bit. I think every time I see a patient, they always ask me, so what stage of sarcoidosis I am? So the stage of sarcoidosis came in the pulmonary case. It's looking based on radiographs. It's been around since 1958. 1960 was consolidated, and then just later down the road, another stage was added. So it would be from stage 0 to stage 4. And there's basically show how much the lungs are involved, and this is just based on a picture. And you will see here stage 0 when there's nothing. That your lungs are perfectly normal, and you probably they did a biopsy somewhere else, in skin or somewhere else. That's where the diagnosis of sarcoidosis was made. Then you have stage 1, which only have inflamed lymph nodes around your lungs. And stage 2, when you have inflamed lymph nodes, but you also have involvement in the lung tissue per se. A little bit of inflammation, a little bit of nodules. Nodules, just a little bit of round particles in your lungs that you can see. Then you have stage 3, when these lymph nodes that were inflamed or enlarged, they're gone, and you only have this inflammation, a little bit of scarring, these nodes in the lung tissue. And then stage 4, just more fibrotic, just more scarring in the lungs, mostly preferentially go in the upper part of the lungs, and that can create these bullets, which is those little air space or cysts on the upper part of the lungs. And I'm going to show you a little bit more pictures, good examples of that. This is a picture of a CAT scan. Just think about being standing up, and in here you see the lungs, or you're seeing somebody. This is another picture when you would take cuts across your chest, across the chest. And what we see here is we see inflamed lymph nodes. And then we were talking about, besides having the inflamed lymph nodes, we have here evidence of infiltration on the lung tissue. Where the lung tissue is affected, you will see this, it's called reticulonodular opacities, which just means there is evidence of inflammation in the lung tissue per se, and it's not only in the lymph nodes. And then here is a little bit more other pictures where it looks like there is scar tissue kind of tracked in the middle of the lungs. This is very typical for sarcoidosis, as it tends to go in the upper part of the lungs, in the middle of the lungs. It states, you see the most disease is in the middle part of the lungs, per se. And then this will be the equivalent of a stage 4 on the X-ray on the CAT scan, where it is destruction of the lung tissue itself. The lung tissue doesn't look like lung tissue anymore, and it's just all scar. And we look here how the upper part, the head is here, feet are here, and you will see here how the upper part is the one that is more affected. So these are all examples that are very typical of patients that have active disease, active sarcoid disease in the lungs. So now let's talk about PET scan. So this is super cool because as technology has advanced, we use PET scans a lot in our clinic to, number one, when we are unsure about the diagnosis and the patient has not had a biopsy, it gives us which areas, if some areas have active inflammation, those are good spots that we could potentially go in and take a piece. It also, there's some data out there that would tell us that if you have a lot of, the PET scan is very light up, there's a lot of inflammation in there, and that could help you make treatment decisions. So this is still an area that is up and coming. There's a lot of research in here, but I think it's promising in regards to figuring out which patients will benefit from aggressive treatment. So talking about treatment, not all patients that have only pulmonary sarcoidosis require treatment. Treatment is favored in patients that are symptomatic, that we have evidence of active inflammation, they are losing lung function, or they have a low likelihood to go into remission by itself. And I put in here this is a shared decision because these medications are hard to take. So there needs to be a conversation with your clinician, with your doctor, the good, the bad, and the ugly, and what will we expect to get from this? And because I can prescribe all the medications that I can and I want, but you are the one that is taking them, and you need to know what are the potential side effects, that you need to come to for blood work every month, and if your blood counts are low, then you need to come even closer than every month, and so forth. And just as we're going with treatment, if we decide that we do treatment, these are some of the medications that we use. Prednisone is kind of the first line just because it's the one that we use the most. Also cytotoxic medications like methotrexate, azathioprine, or mycophenolate, and leflunomide, and infliximab. It's also one of the medications that we use, mostly a third-line agent when patients that have refractory disease or disease that is hard to manage. And in some other patients, lung transplantation, when they continue to decline despite being very aggressive with the management, is the next step. I want to thank you all for being here. I know we were